I've heard this phrase, new culture of dementia care. What does that mean?
Well, in order to understand it, you need to understand the old culture of dementia care. That means we need to go back into history.
Sure.
So this is unusually a disease that's been described, I suppose, like leprosy, right from the very earliest times.
Mm-hmm.
And there are references apparently in ancient Greek to it, certainly in Shakespeare's time, the 7 Ages of Man.
Of course.
I can't remember it exactly offhand, but the last stage is definitely that of senility. And the narrative was of complete doom and gloom. There was really nothing that could be done. You would be looked after in your own home. If you were a person of wealth, you would probably be paid. Somebody would be paid to look after you in your own home. But if your behaviour became too difficult, you would then go to the workhouse or later what turned into the mental hospital, the asylums as they were.
Yes.
And so the future was pretty bleak. And it wasn't until the 1910s when, first of all, Alzheimer's discovered the plaques and tangles, which became Alzheimer's disease, and Dr. Lewy, discovered the Lewy bodies, which became dementia with Lewy bodies.
Right.
So that was both in that same decade. They were both in Vienna. This meant that
it became sort of a medical
Then it became
thing.
a medical thing. Before that, it had not been medical. It had been normal old age.
Yes.
The thing everybody dreads. And this is where the beginning of the stigma, which still surrounds it, this is where its roots lie, deep, deep in our culture. And nothing really very much happened after that. The disease, Alzheimer's discovered these plaques and tangles, but didn't know what they were, but knew that he'd observed them in this patient, Frau Augusti, who was the wife of a man who agreed to let the doctor use her notes and look at her brain after death in exchange for caring for her in his clinic. And then as a result of that piece of work and those very closely written notes, I've actually seen somebody talking about it from the Alzheimer's hospital in Austria. They're all still there, these notes. It's amazing, describing in minute detail the symptoms of dementia.
Right.
And that led to the birth of a disease. But nothing then happened until the 1960s and 70s, when the electronic microscope began to show that these were not normal aging. Up till then, it had still been, this is what happens, this is the aging brain.
Okay.
This woman was known as pre-senile dementia because
she was younger.
Because she was young. She was only 51. In the same sort of period, the CT scan was developed, and that showed the structural shrinkage of the brain.
Right.
So those two things were the markers which we use today. So it was medical. It was strongly, totally medical. And this person was the patient, and it was all about research. And then in the 1980s, you got the voice of the family carer being heard for the first time, which changed a lot of things. In fact, a few years before that, 1976, the Alzheimer's Society was formed by 4 family carers, wives of men who had Alzheimer's. And they began to gather force as a political campaigning movement, not so much providing services, but providing
a voice.
A voice,
yes.
A voice. And it certainly doctors began to have to listen to them. In the 90s, for the first time, technology enabled people to identify that the proteins involved in the plaques and tangles of Alzheimer's were amyloid and tau. So you had this thing called the amyloid hypothesis, which started in the 1990s. And then they also began to map out the stages because imaging was improving. And then also this factor that there are risk factors in middle age.
Right.
And the drugs that we now use were developed at that period. The
Aricept, I remember
and all
that. Yes.
Aricept. And then in the 90s, mid-90s to 2000s, you suddenly get a revolution in this country with the work of Professor Tom Kitwood, who I worked with, who actually coined the phrase, the new culture of dementia care.
Right, okay.
And he developed for the first time a psychosocial model of looking after people with dementia.
Right.
Now, Kitwood was not an original thinker. He took his theory from that of Carl Rogers, who invented person-centered therapy in the 1960s. And I have a quote here, which I think sums up very well the approach that he was advocated. He said, being person-centered is about focusing care on the needs of the individual, ensuring that people's preferences, needs, and values guide clinical decisions, providing care that is respectful and respondent to them. This was the first time that those ideas had really been solidified in psychotherapy. Tom Kitwood adapted those ideas for dementia, and it was revolutionary.
Right. So it was looking beyond
it was
the
looking
dementia
beyond the disease. It's
to
not
the person.
to the person. No longer a disease-led model, but a person-led model.
Right.
And this is what we are totally committed to trying to do. This treating with respect. It's so easy not to do that. And it isn't just because it's to do with age as well as dementia, isn't it? I mean, people are discriminated against in all sorts of different ways.
So I guess it's moving beyond the symptoms towards the sort of care of the unique individual person and thinking about the needs of the individual to maintain their sort of, as you said, that sort of respect.
Yes.
That they're still sort of feel valued as a person, and they still
Yeah.
have that sense of purpose in their life.
Yes. So it's like holistic, it's looking for the whole person. And so we getting the beginnings of a shift away from the totally medical to the psychosocial being developed. I do remember saying to Tom, when I knew him in 98, it's been 10 years, Tom, and it's nothing much has changed. And he said, we are trying to change a culture. This is going to take decades.
Yeah.
And, it is still, there is still so much work to be done, isn't there, in this? Because the dominance of the medical model is so strong.
Yes.
And this is where we all default to.
And those centuries of stigma.
The centuries of stigma is still underlying, it's still there, I think.
Yeah.
So Kitwood showed that, he said that the medical approach just wasn't enough for people with dementia. He showed that the psychological and social approach was equally, if not more important. And he taught that people can be disabled by the way they're treated by those who are caring for them as much as by the disease itself. And this was profoundly shocking and upsetting for a lot of people. But he actually used a flower to talk about the emotional needs. It's known as Kitwood's flower. The needs which are not met, the needs which are likely not to be met if you are a person with dementia, because you can't meet them on your own. You need somebody else to help you to meet those emotional needs.
This is where you need a care partner.
This is where you need a care partner or
it's more
somebody
of
else.
a relationship.
Yes. And this is where the importance of the relationship is. And as you see on the flower, the needs are the need for identity. Now you can see if you can't remember your life story, and if you are put into a strange place, like a care home, you can very quickly lose your sense of identity.
Sure.
Another one is occupation. He didn't mean by that entertainment. Care homes are quite good on the whole at entertainment. What he meant was something to do which validates your previous life, which is related to your previous occupation.
Sense of purpose.
A sense of purpose.
Yes.
Inclusion. How quickly people with dementia are excluded from the family group, from the wider society, and attachment, the need for love, and how often that just isn't there in some care settings. You know, it's all about the task-centred care.
Yes, task-driven. Yeah.
So that is what he was trying very hard to change. And so the work goes on, and we in TIBS Dementia are trying to follow those principles. When I was in hospital recently, I tested myself about whether my emotional needs were being met, and discovered that actually they were all being met, and actually I was fine. I was just physically in need of help, but I had a sense of identity because people knew who I was, and I didn't have dementia. I could talk to people and tell them who I was, and some of them knew who I was. I became friendly with the staff. I made friends with the staff. The occupational needs, because my occupation has been in social care, I could find myself a little role in the ward. I felt included. I felt very much included. And in fact, to the point where when I had months in hospital earlier in the year, I was actually in tears when I left the ward. I felt that I was included, and it was my gang, if you like. And that need for attachment was met because I had my family coming in every day to see me. And so everything, I felt that love that was at the centre of Kidwood's Flower.
Yes.
But if I had dementia, I couldn't meet those needs.
No.
I would be lying in that bed and people would be doing things to me. But
so it's about doing with the person with dementia. Again, it goes back to that looking beyond the dementia, beyond the diagnosis, to the person who's had occupation, who's got a sense of identity, who's got a skill set, who's got experiences to share. If we can just draw them out.
Yes, exactly.
And the Kitwood flower relates to all of us, really,
yes,
whether we have dementia or not.
Yes. He just made the point that they are particularly vulnerable and those needs being met, that they're human needs for all of us.
Sure.
But, you know, and the danger of the task-centred approach is that it doesn't meet those emotional needs.
Of course.
And when you've got, he did almost all his work in care settings, in nursing homes, residential homes. He didn't work in the community. But by the time, you know, you could say there are three different models that we now have as a result. We have the biomedical model, we have the psychosocial model, which is what Tom was talking about. We also have the disability model, which is very interesting because I don't think people with dementia do very well with the dementia, with the disability model, because that's all about rights.
Yes.
And somehow, although there are large numbers of people involved, huge numbers of people involved, there isn't a sense of our rights somehow.
Yes, I get a sense of that people almost acquiesce somehow that it's a dementia, not that I have rights as a person with dementia.
Yes.
And I wonder if with younger people with dementia as well, that's a sort of something that perhaps can come through a bit more strongly. I have dementia, but I still have rights. I still have a right to work if I want to. I have a right to a family life. I have a right to a home life, rather than I just need to be cared for and looked after.
Yes.
I still want to live a fulfilling life.
Yes, exactly. And of course, the big change, going back to the thread of the history, the game changer was the emergence of the voice of people with dementia themselves. When people began to be diagnosed in the early 2000s, it started early enough to be vocal and to tell other people what it's like. And there you have Dementia Alliance International, which is a global organisation of people with dementia who are campaigning very much for us on the disability line. I think trying to change things. People are writing books. We ourselves have used Wendy Mitchell's, very much influenced by her.
Yes.
Christine Bryden. These are real pioneers, and I think it's the only way that the dominance of the medical model is going to be challenged.
And the only way we can understand what's going on really for people. And I remember in those early days of Tibbs when we had clear voices and how we were both just completely blown away in those early sessions that people with dementia had a strong voice, had such insight. And I think we both learned a huge amount from listening to the voice of people with dementia. And we went up to Scotland together, we went to the Scottish Dementia Working Group.
They were a big influence on this.
And there was about 100 people with dementia sitting in the room and running their own conference. And
we thought, this isn't possible.
Yes, and they did. And they campaigned, they helped to influence the Scottish Parliament decisions on dementia, a really strong and influential voice. And I think, that shows that we can't just sort of say, well, it's dementia, the person can't understand or hasn't got a voice, and it's to us to help that voice be heard.
Exactly. And I think that's where we're at now. So although Kate Wood's work was done, as I said, almost exclusively in residential, institutional settings, all his research about malignant social psychology and the way people are treated. We are sort of pioneering how you use this approach in the community. And that's where I think we are at. This is where we stand.
And I think when we think about experts through experience, we have ambassadors who are people with dementia now who are prepared to go and speak at events and to say it as it is. We had our Clear Voices group who themselves spoke at conferences, and they made that pamphlet about what dementia means to us. So that voice is really coming through. We just need to help it to be heard and to be amplified.
Hold on to it, because it's so easy to slip back into the biomedical model and handing out the tablets. Isn't it? It's quick, it's easy, it's cheap. This all takes time, it takes skill, it takes care, it takes love, it takes commitment. And it's a fight that is ongoing.